Assalamu alaikum everyone. Shall I start?
Yes, yes.
Good morning. I'm Dr. Farzeen Zahra, and today I'm going to present on the topic of pre-transplant assessment in this series of core urology lecture. So before starting, let's have some introduction. Renal transplantation is most preferred method of renal replacement therapy for patients with ESRD. All patients with ESRD, that is end-stage renal disease, should be offered transplantation unless absolute contraindications exist. But before going for transplantation, every patient has to go through a series of investigations to evaluate that even if that patient is fit for the transplant. The reason is that the patient should have the survival advantage of transplantation. We should minimize the morbidity and mortality and maximize the quality of life. That should be our ultimate aim. And as there is a scarce resource of living and deceased donor kidneys, so we should use them wisely. Patients should be referred to a transplant program when they approach stage 4 CKD or the GFR is less than 30 ml per minute. Transplantation before the commencement of dialysis, called preemptive transplantation, improves post-transplantation graft and patient survival. The 5 and 10-year graft survival rates are 20% and 30% better in patients who receive either no dialysis or less than 6 months of dialysis than for those who receive more than 2 years of dialysis before the transplant. So from this, we get the message that we should refer the patients for transplantation as soon as possible because that increases the graft survival rate. Now let's talk about some cases.
But our protocol is that we are not doing the preemptive transplant. We are doing the if the patient has on dialysis, then we'll start the transplant workup. Okay. Basically, we are doing the living donor transplant. We are not doing the diseased donor, and because of many problem in the society and awareness of the society, so we are only stuck to the living donor transplant. Okay.
Just for correction of and to make it a part of record, we haven't done it the preemptive transplant in the recent times, but we have done only I think one or two cases in 1980s in the very first decade of our transplant program. So we have been doing it, but the practice has been say it hasn't been on a routine basis. But this is something which has to be looked into because now the dialysis unit is working more efficiently as compared to 90s and early 2000. So now is the time that we must look into it because there are many benefits of doing preemptive transplant vis-a-vis health status of the patients. Because once they are on chronic dialysis, there are many difficulties which you encounter and the patient encounter after transplant.
But in some cases, there are also contraindications. In these cases, we should avoid transplantation. These contraindications are active malignancy, active infection, severe vasculitis, significant CVS disease, active SLE, primary hyperoxaluria. In this case, we can combine the renal transplantation with the liver transplantation, untreated psychological disorders, and avid drug users and alcoholics. So there are some important questions that there should be answers before a patient has to go for transplantation. What is the cause of end-stage renal disease in a particular patient, and what are the risks of recurrence? Are there any psychological or financial problems that could prevent compliance in post-transplant care? Is active infection or malignancy present? Or are there any anatomical or functional barriers to technical success? Are there any immunological risk factors? What would be the survival of patient without end-stage renal disease? And the important question, especially in our setup, is there any potential living donor? So there are some cases in which there are some causes of end-stage renal disease in which there are risk of recurrence in the graft kidney as well. Primary axalosis, as I have told before, in these cases we can combine renal transplantation with the liver transplantation. Cystinosis, atypical hemolytic uremic syndrome, focal segmental glomerulosclerosis, membranous nephropathy, IgA nephropathy, systematic lupus erythematosus, renal amyloidosis, and ANCA-associated vasculitis and Fabry disease. In these cases, there's always the chance of recurrence after the transplantation has been done. Whereas there are also some diseases in which there is very less risk of recurrence or no risk of recurrence. For example, polycystic renal disease, renal dysplasia, and chronic pyelonephritis. So first talk about psychological and financial problems. Non-compliance with complex post-transplant regimen is preventable cause of kidney graft loss. It's important to identify any psychological and financial problems that could result in non-compliance. Pre-transplant nurse coordinators, pharmacy, social service, and financial services provides this information, and they also provides the solution. Another important aspect to look into is active infections, because in the case of active infections, we can't go for transplantation because we also have to give immunosuppression to the patient. Meningococcal vaccine is recommended for asthenic patients. Hepatitis C has to be treated before transplantation has to be done. Patients with active hepatitis B and C are excluded from transplant unless the hepatology department gives the thumbs up that we can do it. A screening for pulmonary infections which checks X-ray and tuberculosis tests. Patients with inactive tuberculosis usually receive months of prophylactic isoniazid. UTIs must be resolved or controlled prior to transplant. Prophylactic segmental colectomy may be necessary for patients with recurrent diverticulitis. CMV antibody levels are determined because CMV infection in the post-transplant patients can result in significant morbidity and mortality. The HIV positive patients may qualify for transplant if CD4 lymphocyte count is satisfactory. Malignancy. So, in the case of genitourinary malignancies, there is the recommended waiting year before we can go for a transplant. So, if the kidney is T1, if the kidney has T1A and not an M not stage, and the grading in any grading, we don't have to wait and we can go for transplant. And in also T1B with Furman grade 1 and 2, we can go for transplant without any waiting year. But if the disease is T1B and Furman is grade 3 and 4, we have to wait for like at least 2 years. And if the grade is more than 2, we again have to wait for 2 years. Again, for the low risk and intermediate risk prostate cancers, we can go for transplant without any waiting year. But for highest risk prostate cancer, we have to wait for 2 years. For transitional cell carcinoma of bladder, if the stage is less than T1 and the tumor is focal, we can go for the transplant without any waiting year. But for T1 and more than T1, we have to wait for 2 years before going for transplantation. Another important aspect in the pre-transplant evaluation is urinary tract evaluation. There are certain important questions that we have to answer before going for transplant. Does the bladder or its substitute fill? Is the bladder or its substitute empty? Is the patient dry? Is there a prostatic reservoir to be avoided at the time of transplant? Is there any artificial urinary sphincter to be opened at the time of transplant? Is any genitourinary cancer present? And should the native kidney comes out? Now, there are certain indications in which the native kidney should come out, and we have to do pre-transplant nephrectomy. In such cases are uncontrolled hypertension, recurrent pyelonephritis, renal calculi not removable by minimally invasive procedures. There is significant proteinuria, and in that cases we could also consider angioembolization, persistent anti-glomerular basement membrane antibodies, the presence of solid tumors in kidney, and polycystic kidney. So in all these cases, we should go for pre-transplant nephrectomy. The most important factor in any transplant is immunologic evaluation. HLA graft survival is better with fewer mismatches. Generally, the donor and recipient must be blood group compatible. Whether a particular kidney can be transplanted is determined by a final cross match that measures whether the recipient has an antibody to the donor kidney. There are 3 steps in the donor and recipient matching. Are they ABO compatible? The HLA, A, B, and TR phenotype, and to check the lymphocyte cross-match test. This is done to avoid hyperacute rejection. ABO compatibility. Blood group antigens can behave as a strong transplant recipient, as strong transplant antigens because of their expression on renal vascular endothelium. The ABO incompatibility may cause early hyperacute rejection. Group O donor theoretically can be a transplant to A, B, or AB recipients. In the cases of the ABO incompatible transplant, we can go for antibody elimination through anti-B agents. HLA matching. Transplant outcomes correlate with number of HLA mismatch. There is remarkable polymorphism that is present, and we must determine HLA-A, HLA-B, and HLA-DR phenotype before going for a transplant. The HLA incompatibility can lead to cellular and humoral graft rejection. Cross-matching. It detects preformed allo antibodies in recipient's serum directed against lymphocytes of potential donor. Patients with history of pregnancy, transfusions, and previous transplantations are at greater risk. Positive T cell crossmatch is contraindication for transplantation, whereas for positive B cell crossmatch, we can do therapy with anti B cells and with anti B cell, which includes rituximab and alemtuzumab. Before going for the transplantation, we should also do the life expectancy calculation, which is based on Charlson comorbidity score. The 10-year life expectancy for scores of 1, 3, 5, and 7 are 96%, 22%, 21%, and 2% respectively. So here's the chart which helps us to calculate the Charlson score, which tells the different diseases in which the score is 1. So if there's any heart disease like myocardial infarction or the history of congestive heart failure, peripheral vascular disease, cerebral vascular disease, dementia, chronic pulmonary disease, connective tissue disease, rheumatic disease, peptic ulcer disease, and mild ulcer disease. And so the score is 1. Whereas if there is diabetes with complications, paraplegia, hemiplegia, renal disease, and cancers, the score is 2. For moderate or severe liver disease, the score is 3. And for metastatic carcinoma and HIV, the score is 6. So the higher the score, the lesser is the life expectancy calculation. We should also go for the important imagings before going for a transplant. That includes chest X-ray, ultrasound abdomen L pelvis, CT abdomen, and lower limb venogram of recipient. So this is the slide which summarizes the everything which we have gone through up till now. After the referral for a renal transplant evaluation, there are few important questions that have to be answered, like is there any history of prior substance abuse, morbid obesity, compliance issues, high risk for heart disease. If the answer is yes to any of these questions, we should manage accordingly. And if the answer is no and the patient is low risk, we should go for further investigations. That includes a series of investigations. We have to list on all the problems the patient has, medical problems, medical history, immunization history. We should examine the patient thoroughly. All the tests, a lot of tests have to be done. Pap smear has to be done in the woman. For the woman more than 40 years, we have to go for the mammogram. Eye exam has to be done for the patients more than 50 years and who are also diabetic. Some baseline tests, EKG, ultrasounds, everything has to be done. And the PSA has to be done for the men who are more than or equal to 40 years. Urine cultures are also an important part of the examination, important part of the investigations. Dental examinations. After all these, we should also consult the social service department. We should do dietary consult. Family should be educated. Patient should be educated. Financial counseling has been done. In our setup, we provide the medications, but if we talk about worldwide, the medications that has to be provided after the transplantation, they're quite expensive. So we have to consult the patients financially as well, and of course, histocompatibility testing. So after, so as indicated, we should also go for these spatial studies and spatial consults. Like every patient is individual and they have individual needs. They have their individual investigations as well. Like for example, for a woman more than 40 years, we should go for a mammogram. So we should go through all those investigations and. After going through all those investigations, we if the patient is fit, if they are fitting all the criteria, or and if they're not fitting that in those criteria, if those criteria are corrected, then patient can go for a transplantation. So it's a very long journey in which they have to go through a lot of things, a lot of investigations, tests, and after all these things has been done, the patient is accepted for a transplantation.
What is the special studies? In which patient will do the special studies? Vikalpa. I did. किस पेशेंट में करना चाहिए? किस कोई और बताएगा? Suppose if the patient comes with the PUV and there's a bilateral hydronephros hydroureter and patient is ESRD, then what tests you will do? These tests should be done in that type in that patient. So which tests you will do? कौन से करेंगे?
So if the patient has previous any bladder disease, then we have to look for the bladder. Yes.
So
Bladder pathology.
for bladder.
So we'll do the pre-transplant cystoscopy, the routine test.
First we have to do the non-invasive test,
Invasive
which is
Hydrodynamics.
X-ray MCU.
XMC.
So in X-ray MCU, what we will see on the side? Yes, one is reflex and
Reflex देखते हैं, bladder contour देखते हैं, तो shape of the bladder, if there is any irregularity, pan-shaped bladder or not. And
the second thing is shape of the bladder. It is regular or it is irregular.
the presence of persistent posterior valve or not.
Okay, if the posterior urethral is dilated or not, and there is a shape or something like this deformity there in the X-ray and shape, or
Presence of any diverticulum.
yes, any diverticulum in the urethra or any stricture in the urethra, because there may be a issue of PUV ablation, so there may be a site of stricture in the PUV. Okay, and you have done the X-ray and CUG, and there is a bilateral grade 5 reflux, and the bladder capacity is small. And how you will proceed for the patient? Okay.
Then we'll plan for augmentation.
Okay.
Then we'll proceed for transplant in later stage.
Is there any need of bilateral augmentation? So we have seen a slide that when we have to do the pre-text and so polycystic kidney disease में भी जो है वो indications हैं. Every polycystic kidney should not be removed.
Uncontrolled hypertension, polycystic kidney disease, active malignancy, solid tumors,
If there is solid tumor in the polycystic kidney, then we have to remove.
pyelonephritis,
And
pyelonephrosis.
we need space in the right PA fossa. If the polycystic kidney is very large and the lower pole of the kidney is lower to the iliac crest, then we have to remove the polycystic.
The BR kidneys.
So we have to do the bilateral nephrectomy, and if the bladder is small, then we have to perform the video urodynamics to document our bladder is non-compliant and small capacity, and then we have to do the cystoscopy biopsy without TB because TB is very rampant in our area. So then if TB is not there, then we have to do the augmentation cystoplasty as we talked about, and then we proceed for the transplant after TB. Suppose there is a stone and kidney are studded with the stone, then what will do? कोई और बता दे बेटी तो आप क्या सस्पेक्ट कर सकते हैं 10-year boy come with the studded kidney bilateral stone, stag on stone are there and he is hard.
Certain
तो हमने क्या क्या एक चीज डेवलपमेंट करनी है
functions के renal function.
Hyperoxaluria. Oxaluria.
So how will you evaluate the primary hydroxyurea?
Metabolic workup.
Okay. So what is the sensitive and specific 100% sensitive and specific test for primary hyperoxaluria. Genetic history for pH1 and pH2. If genetic history for pH1 is negative, then there will be a less chance of it. It is 100% sensitive specific. So if the genetic history is negative, then primary hyperoxaluria is excluded. We usually do the biopsy as well. We can take the biopsy from anywhere. We can take the biopsy from liver. We can take the biopsy from kidney. We usually do the pre-taste nephrectomy. So to document that there is no primary or hyperoxaluria in this one, then we have to proceed to the transplant.
So this was all about the recipient worker. Now let's move forward towards the donor work. So the donor can be cadaveric, he can be the live donor. If the patient is cadaveric, he might have the brainstem death or there could be circulatory arrest. Okay, so the question is who can donate the kidneys? Monozygotic twins, HLA, identical siblings, haploidentical siblings, parents, children, other relatives, zero haplotype relatives, living unrelated, like for example, spouses and friends, deceased donors. In our setup, we only accept living related donors. So the donor workup starts with the history.
Sure. There is one more class of donors. It might not exist today in our society, but it might happen in future, because this is the group which is there in the West, and that is known as non-directional donor. Meaning to say, somebody wants to donate the kidney, and he or she doesn't want herself or himself to be known, that where the kidney is going or where the organ is going, any organ, right? So, for instance, this can be done during lifetime. This can be done as a deceased donor. फॉर इंस्टेंस मैं अपनी विल में लिख देता हूँ कि बाद में मेरी बॉडी जो है वो इस्तेमाल हो सकते हैं. सो वो जो नॉन डायरेक्शनल डोनर होता है वो अपने विल से अपनी लाइफ में ही कह सकता है कि आप मेरी आज किडनी ले लें. आई डोंट वांट इट बिकॉज आई एम अ हेल्दी पर्सन. लेकिन उसके लिए एक पूरा प्रोसेस है. सो देयर इज अ लीगल प्रोसेस that actually provides the umbrella under which everything is going. But you need to have a network. For instance, in America, there is a network known as UNOS. So UNOS takes care of all these things, where that donor kidney goes, because they have got the waiting list. So nobody knows where the kidney is actually going or where the liver is actually going, partial liver. So these are two organs, and also sometimes in cases of intestinal anomalies, the donation of intestine can be done. So you might find instances where this non-directional donor is actually playing a very pivotal role. But again, this is something which is very, very rare or very distant kind of wish in our society. But this might happen.
So the donor work curve starts with the history. We should focus on the relationship and with any renal disease. Like for example, if that patient is the known case of hypertension, diabetes, any family history of any known renal disease or any other disease, is there any history of the NSAIDs, any other chronic drugs that have been used, the environmental exposure to the heavy metals, chronic UTI, stones, and history of prior surgery, any prior cardiovascular or pulmonary events, like for example, the presence of TB. So we should also begin to explore the desire to donate. That why that patient is why that the donor wants to donate the kidney in the first place. Then we should move towards the physical examination. Again, we should start with the baseline, like for example, blood pressure, weight, height, BMI, for general physical examination, and another important thing is the cardiovascular disease assessment. Then laboratory testing should be done, urine analysis, cultures, electrolytes, CBC, UC, lipid profile, liver panel, all of these should be done. Coagulation screening should be done. 24-hour urine test, creatinine clearance, and protein excretion, albumin creatinine ratio or GFR measurement has to be done. I need more stone history. That should be taken from the 24-hour urine calcium, uric acid, oxalate, and citrate. We should check this viral serology of the patient, and we should check in for any HIV, Epstein-Barr virus, CMV virus, herpes, and we should do the electrocardiogram, chest X-ray. In the females, we have to do the pap smear, mammogram if the age is appropriate. In males, we have to do PSA, and in the age-appropriate patients, you can also go for the colonoscopy. And before going for the transplant, we should do the imaging of the donor kidney, uh, whether through the CT or the CT angiogram or the magnetic resonant angiogram. Now, there are also some contraindications of living kidney donors, like we shouldn't accept the kidney from anybody who is willing to give it. The absolute contraindications are the evidence of any renal disease, GFR. If the GFR is less than 80 and there is macroalbuminuria, then obviously the patient himself is in the danger of having a significant kidney disease in the future. He shouldn't donate the one he has. Significant renal and neurological abnormalities, transmissible infectious disease like, for example, HIV, hepatitis B and C. Is there any active malignancy? Is there the poorly controlled psychiatric illness in the donor? Any congenital deficit? If the donor is pregnant currently, uncontrolled hypertension, diabetes mellitus, and recurrent nephrolithiasis or bilateral renal stones. There are some relative contraindications as well, like for example, if the age is more than 65 years or less than 18 years, and if there's borderline or mild hypertension and obesity. So
Fuzzy. So which kidney is better for donor nephrectomy? कौन बताएगा? हमारे रेजिडेंट कोई? Left side. Okay, Noman will tell that why left side.
Long length of renal artery.
Long length of renal artery
Oh,
or
so
renal
renal
vein.
vein. Renal vein.
So there is a long renal vein on the left side, so that's why left kidney is better. But in pregnant women, like in the age of 30 to 40, if the donor is a female, then which kidney?
Right.
Okay, why?
Because in the age of childbearing age, there is chance of physiological obstruction or hydronephrosis on the right side. Left
So-
is spares.
Yes. So better kidney should be left in the donor, and a compromised kidney should be taken from the donor. Okay. Suppose you have two arteries on the left side and or three arteries on the left side and one artery on the right side. Which kidney you will take?
It is easy to take the kidney with single artery rather than the two or three.
Okay, if you are taking the right kidney, right donor nephrectomy, then what you will do for the vein? Vein is small on the right side.
We can take the patch of IVC.
Okay, so we have to take the IVC page. If you will not take the IVC page, then there will be a disaster happening after anastomosis of the vein, and there will be a gross leakage if you will not take the IVC patch. You have to take the IVC patch to lengthen the right-sided vein during donor nephrectomy.
Acha, this is a question which is often asked: which if the two kidneys are normal, the vascular architecture is normal. Normal means there is no duplication. So which side should be taken? And often the answer is the left, and you always say that it is the length of the renal vein that is that is there on the left side. But practically speaking, that is not the case. Practically speaking, it doesn't matter if you are in a center that is a high volume center where probably 2 transplants are done each day. So this doesn't matter whether it's the right side or the left side. Dr. Sufi Saab is here. Sir, does it matter or it doesn't matter?
Technically, If you have the expertise, I don't think you can manage with smaller, shorter veins also. Taking it's not necessary to always take a patch if you're taking the right kidney. If there's sometimes the length of the vein is reasonable and you don't need to take the patch of the IVC. But taking a patch will help lengthen that. But you have to make sure you don't narrow the IVC too much.
Why I'm stressing on this point is once I was in Lahore in one of the centers, and there was a discussion on transplant. And most of the surgeons over there, they were not all of them, but some of them were actually doing commercial transplant, and we have to tackle those persons also, because they are doing technically the same thing that we are doing on a non-commercial basis. So taking aside the commercial aspect of it, uh, our protocol of doing, for instance, angiograms, earlier it was a conventional angiogram and now it's a CT angiogram. uh, this is something which is not done on a commercial transplant program, because they are just cutting the corners, and they want to make money as quickly as possible. So they always cut something which is, according to them, not needed. So my assumption and presumption, and to my colleagues, I have to say them that if you are going towards some area which is uncharted, without any plan, without any map, you will always land up in problems. And the counter argument from their side was, if you are a skillful surgeon, it doesn't matter whether the duplication of artery is there on one side or not. So it's always a case of technical expertise. If you have it, then there is no problem. But taking aside all these things, if you go step by step and you see the angiogram, and you are the surgeon who has to do the donor nephrectomy, and later you are on the transplants on the recipient side also, then you are always in the process of thinking that what is the caliber of the vessel, what is the length of the vessel, how much it has to be taken, no matter what side it is, it doesn't matter. And no matter what side of the recipient you are putting the kidney in, because it's just a matter of taking the best of the best vessel for anastomosis and taking the best possible chance for the recipient to work, recipient side to work. So always think in terms of something which is tangible, which is reproducible, which you can always see yourself, just like a CT angiogram. You always see once, twice, maybe thrice. You can take advice from the vascular surgeon. If you think that there is a duplication which you cannot tackle, then you can always have an idea from other side also. So always think technically rather than going by a blanket statement that I have to go towards left side no matter what happens.
Yeah, I think it might be different in the rest of the world where you're doing cadaveric transplants. There you already have the kidney in front of you and you know what the anatomy looks like. So probably, I'm not sure of the literature, but an angiogram might not be a part of the donor workup over there. Because I mean, if they have a living related or living donor, maybe they'd go for an angiogram. So here we routinely do them because all our, I mean, nearly 100% of our donors are living. So I don't know what your normal text in a textbook would be saying about this, but you can't make it a rule. So be careful when you're answering a question, whether it's a donor, it's a living donor, or a diseased donor.
Ji.
So, what are the advantages and disadvantages of living donor transplantation? The advantages are we can select the donor for haplotype match age. There are better outcomes. The minimal delayed graft function. We don't have to wait for diseased donor kidney, and we can plan the transplant as per convenience. Immunosuppressive regimen can be less aggressive. There is the emotional gain to the donor that he has done something good. The disadvantages are that there is psychological stress to the donor as well, like before going for a surgery or even after surgery, that something might happen to him. Something might happen to his one good left kidney. There's long donor evaluation process. There can be mortality in the donors as well, which is very rare, but it is present. The donor might have any major and minor complications. Potential hypertension and proteinuria in the donors, risk of trauma to the remaining kidney, and risk of an unrecognized covert renal disease. If we talk about the disease donor, what is the criteria for an ideal disease donor? The disease donor should have the normal renal functions, no hypertension that had required treatment in his lifetime, no history of the diabetes mellitus in the disease donor, no malignancy other than primary brain tumor or treated superficial skin cancers, no generalized bacterial or viral infection, the acceptable urine analysis, and the age of the disease donor at the time of the death should be between 6 to 50 years. Negative assay for syphilis, hepatitis, and HIV. There are the categories of disease donor as well. To maximize kidney units, following categories have been developed. The standard criteria is that most individuals that meet the criteria for brain death from age 5 to 60 years with normal kidney functions and no history of systematic or infectious disease. The expanded criteria of the donors is that kidneys from brain dead donors with 1.7 times of relative risk of graft failure. These include any donor of age more than 60 years, age of more than 50 years with history of hypertension. The CVA is the cause of the death, like cerebrovascular accident, and the creatinine was more than 1.5 milligram per deciliter in the diseased donor. So there is 1.7 times more risk of graft failure in these expanded criteria donors. Now let's talk about mismatch transplant. The best match is when all antigens between a donor and the recipient are same. Like for example, identical twins, and some siblings can have all antigen match, but kidney can be transplanted between two peoples with no antigen match. There are different strategies to make an ABO incompatible and a mismatch trans successful. One is the removal of antibodies, and the second is reducing the production of the antibodies. So the plasmapheresis is that procedure which will remove preformed antibodies, and we can also do the cessation of antibody production with the splenectomy, ATG induction, and the maintenance of immunosuppression. So be a hero, be an organ donor. This is the message. Two lives that are intervened by a miracle with donations. Thank you for your attention.